hope you can see this, but she's not here, and she asked me to give the talk on twins. So it's not my talk. If I say something wrong, don't blame me, it's her slides. So this is ultrasound in a multiple pregnancy. So the first question is really, how are twins made? We are speaking about science here, so I'm not speaking about anything else, how they are made. So we can have dizygotic, dichorionic, diamniotic twins when there are two ova fertilized by two sperm cells, and then everything will be double, okay? 2 chorion, 2 amnion, 2 placenta. Sometimes they fuse, but in general 2 placenta. That's 75% of all pregnancies. They're also called fraternal twins or non-identical. Now, it's easy to recognize them because early, if you look at the ovaries, there are 2 separate corpora lutea, as you can see on the right side of the image. Now, quintuplets, if they are di-di, will have 5 chorion, 5 amnion, 5 placenta, 5 yolk sac, and 5 corpora lutea, usually secondary to induction of ovulation by medications. So monozygotic twins are slightly different, of course. No, they're very different. It's one ova that splits. So depending on when that ova, that fertilized ovum splits, we can have different types. So if it splits very, very early, 25% of cases will have dichorionic, diamniotic. So if I ask a medical student or a resident, here are twins that on ultrasound appear diamniotic, dichorionic. Are they monozygotic or dizygotic? The answer has to be, I don't know. Because, as I said earlier, dizygotic twins will always be dichorionic, diamniotic. But monozygotic twins, if the split is very early, will also be diamniotic, dichorionic. So if we just say diamniotic, dichorionic, we cannot know if they're really monozygotic or dizygotic. So if the split is later, when some formation has already occurred, we'll have monochorionic diamniotic twin. That's after the inner cell mass has split. If we have a little later, that's 5 to 13 days, we have monochorionic, monoamniotic twins. That is, the 2 fetuses are within the same sac. There's 1 amnion, 1 chorion. And then if they split even later, after 13 days, we have conjoined twins, which is very rare. Now, monozygotic twins can be of 2 types, symmetrical when they're separate or joined, and asymmetrical, and you can have, for instance, the middle one is fetus in fetu, we can have trap sequence, or we can have a parasitic fetus on top of the normal fetus. So as we said, the split is between 8 and 13 days. It's less than 1% of the monochorionic twins. When we look at ultrasound, we can see that there are 2 fetuses within 1 sac, same gender, although of course in the first trimester at 8-10 weeks, we cannot see the gender. But if we see 1 chorion, 1 amnion, 1 yolk sac, and 2 fetuses, we can decide that these are monochorionic, monoamniotic twins. They're single placenta. There's no dividing membrane, as you can see on top, and the cord insertions are very, very close to each other, and very often we will have cord entanglement with knots of the cords in a very high percentage of cases. Now, if the split is after 13 weeks, we have conjoined twins, and we can diagnose this in general very, very early. The diagnosis is made by the fact that the two twins move simultaneously. You cannot separate one from the other. So these are monochorionic, monoamniotic conjoined twins, and of course a very severe complication. Now, monochorionic diamniotic twins, there are some clues. There's a single placenta, there's one chorionic sac, two yolk sac, and in fact the number of yolk sac will tell you the number of amnions. So there are two amnions, two embryo, they're the same gender, but again, early in pregnancy, we cannot know that. I want to add something that very rarely, and of course they'll be the same genetic component because they come from one egg, but occasionally they will be genetically different. It's very, very rare, but there is post-fertilization genetic changes that can occur, and then all of a sudden you have identical twins that are not really identical. So it's a rare phenomenon, but it's something to keep in mind that this may occur. Now, if we look at the dividing membrane in monochorionic diamniotic twins, it's very, very thin, it's mobile, it floats, and there are ways to be sure that you look at the membrane. Now, you can have the same phenomenon with triplets. Now, you can have 3 fetuses in a single chorionic sac, and then you have monochorionic triamniotic twins, same gender with the limitation that I just said, single placental mass, 3 amnion, a yolk sac, and a thin dividing membrane. You can also have a combination. So you may have, at first, twins, dizygotic, and then one of them splits in 2. So you have a combination of dizygosity and monozygosity, which is relatively rare, but we've seen that several times. The monochorionic twins are at quite high risk because only 1/3 really won't have any complications. In some cases, both will perish. If we compare the complications between dichorionic and monochorionic twins, you see that there's a higher rate of miscarriage, co-twin death, perinatal death, that's the right column, neurological problem in almost 20%, FGR in 20%, twice as much as in dizygotic twins, preterm delivery almost twice as much, and NICU admission is also higher. So dichorionic diamniotic twins, 2 fetuses, 2 chorionic sac, 2 amniotic sac, 2 yolk sac. The membrane is thick. You can see how thick that membrane is. And it has what is called a twin peak. Later in the pregnancy, let's see if we have, we can't see the arrow, okay. Do we have a, I said no. Okay, so you can see the very thick membrane and the fact that the connection to the placenta forms a lambda or twin peak, as opposed to the thin membrane connecting to the placenta forms a T, which makes the difference between the two. So here are trichorionic triamniotic twins. You can see in the 3D representation how thick the membranes are, and each one has their own chorionic sac, their own amniotic sac, and their own yolk sac. What is the best time to scan a pregnancy to determine the chorionicity? Probably around 10 to 14 weeks. Now, if you scan twins, determining the chorionicity and amnionicity is very, very important because of all the complications that I mentioned. Therefore, if you are reporting on twins, this has to be part of the report. I've seen many reports where it says twin pregnancy, both twins are equal size, the placenta is this, not a word on chorionicity and amnionicity. This is an error. If you perform ultrasound in twins and write a report, you have to mention the chorionicity and the amnionicity. There are cases where there is chromosomal plane discordance, and very often this can be an early sign, very early sign of later development of twin-twin transfusion syndrome, and it's easier to see around 7 to 10 weeks than a little later. And to look at the membrane and the connection to the placenta is certainly much easier earlier in pregnancy than later. Sometimes it helps to roll the mother on her side to cause the fetus to fall on the membrane. That helps you see the membrane, because obviously if there is a membrane and you turn the mother on the side, the fetus will drop but stop at the membrane. That may help you to see the actual membrane. So when you scan a multiple pregnancy, you have to use a very systematic approach. Mention the number, the viability, the chorionicity, the number of yolk sac and amnions. Compare the size, because again, a difference in size may be a predictor of twin-twin transfusion syndrome or a predictor of a genetic problem in the smaller twin. You compare the size, you define the placenta location, the cord insertion, and the amniotic fluid. Now, you look at the dividing membrane. Is it mobile or not? Is it a twin peak or a T sign? Look at the cord insertion, because of course, as we said, there's the risk of cord entanglement. Look at the deepest pocket of fluid. In the past, we used to do the amniotic fluid index, which is measuring the vertical pocket in 4 quadrants of the abdomen. You can't do that in twins, obviously. So what we do is the deepest pocket in one place in the 2 different sacs and compare it. In terms of Doppler velocity, we perform that from 16 weeks on, except if there's a larger weight difference. Now, 2 questions that sometimes are asked is, well, how do you date the pregnancy if there is a discordance? And the second question, which really is the first question, what is growth discordance? When do you call it discordant twins? And there are various definitions. In the past, we used to say, well, it has to be a 25% difference in the estimated fetal weight. I think that if it's 20%, we tend to say, well, 20% is enough to call it a weight discrepancy. Usually, the small fetus is the one with a problem, not the large fetus. So if there is a major difference, we will date the pregnancy by the large fetus and call the other one FGR. It is very rare to have the other way around when one is normal and the other one is macrosomic. Because if the macrosomia is due to diabetes, for instance, both fetuses will be large. So in general, the small fetus, the discordant growth, is the one, the small one is the one that is usually abnormal. How do we assign twins? Usually what we say is the one closest to the internal os is twin A. They can change position, but obviously if there are different genders, a male and a female, it's easier to call them twin A, twin B, because even if they change position, we will continue to call twin A the one that was originally the first one, because if you don't do that, you can't compare the weight if you confuse A and B. So in general, we keep A and B. In 10% of cases, the membrane is actually horizontal, which makes it easier to determine which one is A and B, and they won't switch. So twin A is the one presenting with respect to the internal loss. May be hard to do in the first trimester, but again, as you can see here, there's one that is closer to the internal loss than the other one, that will be twin A. As I said, we measure the twins separately, or the triplets. We don't average. So if one is appropriate for 20 weeks and the other one is appropriate for 18 weeks, we're not going to call this pregnancy 19 weeks. We'll call it 20 weeks with a smaller fetus. The aneuploidy risk is increased. The chron-rump length, there can be 3 to 5% difference between the two, and that's not pathological. But if the difference is more than 10%, there's certainly an increased risk of fetal anomaly, growth restriction later in pregnancy, or a prediction of twin-twin transfusion syndrome. We scan the dichorionic twin monthly and the monochorionic twins every 2 weeks from 12 weeks on. Why do we scan the monochorionic twins more often? As I said, there's a much higher risk of complication. Therefore, this is the time where we scan them. So here are discordant twins at 7 weeks. The one on the right is normal, the one on the left is small. You can see that it's not only a difference in size, but also a difference in the volume of amniotic fluid. Obviously, the one on the right has a lot of fluid. The one on the left has much less fluid. Is that an early sign of twin-twin transfusion with a recipient and a donor? Maybe. Here is another case where one twin, these are dichorionic diamniotic. On the right is a normal twin with a fetal heartbeat. On the left, there's no heartbeat, so this is the demise of one twin. If we had not performed the scan here, but waited 2 or 3 weeks, we would not have seen that demised twin, and this is what is called the vanishing twin syndrome, which has its own issues, of course. There is placental sharing. We need to document where each cord inserts. On the top you can see those sharing. You can have marginal cord insertion, as in the lower right picture, left picture, and the question is, will that cause fetal growth restriction? There are those who say that this may be a reason for growth restriction. So what do we do in the second and third trimester? We certainly do fetal biometry. We measure the cervical length because there's a higher risk, of course, of preterm delivery. We do images of the bladder, kidney, abdomen, lateral ventricles of both. Single pocket, as I said. Look at the membrane, look at the umbilical artery. If we do the MCA, if there's discordant growth, and we've heard the reasons why to do the MCA, and don't forget that the exam will take much longer than usual. So we do image one next to the other, the abdomen, the hearts, the bladder, A and B together to show that they're the same. Fetal growth restriction is certainly increased in monochorionic twins, and Doppler is extremely useful. We've heard the previous talk about singletons, but obviously this is important in twins as well. If we do a EFW and the CPR, and there's a difference between the two, there's an increased risk of that twin dying prior to term. and we consider delivery after 32 weeks if there is a 25% discordance. Amniotic fluid, we use the same charts as singleton fetuses. The single deepest pocket is the best choice because AFI is difficult to do. And really, in the literature, there's no method that seems better than the other, but single pocket is easier to do, and therefore, this is certainly what we do. We use color Doppler to make sure there's no cord in that pocket, because according to some literature, that negates that measurement. No pressure on the abdomen, and the normal measurement is 2 to 8 centimeters. And we compare the two sides. You can see that the amniotic fluid on the right has normal fluid. On the left, there's some echogenicity. This is a patient who received a blow to the stomach, and there was bleeding in one sac and not in the other. The risk of TTTS or TOPS, all monochorionic twins have a single placenta. Therefore, there are always vascular anastomosis. Inter-twin difference 25%. Early predictor is that difference. Classic onset is around 16 to 24 weeks. And there's, of course, the twin oligohydramnios polyhydramnios syndrome. As is clearly seen on that image on top, there's a lot of fluid, normal fetus in the bottom, very little fluid, and if there's an imbalance in the connections, in the AV connections in the placenta, this is TTTS. There are several degrees, from 1 to 5. This is the quinteral stages. 5 is death of both fetuses. There are various treatments that we can do: amnioreduction, septotomy, laser ablation, which seems to be the best. TRAPS is a certain form, twin reverse arterial perfusion sequence. It's the most severe, but also the rarest, and intervention is critical. Some do radioablation of the umbilical cord of the abnormal twin. That's certainly one possibility. So in conclusion, follow the fetal assignment from early scan. Accurate biometry is extremely important when tracking the multi-fetus pregnancy. It is better to use the same machine and the same sonographer, technician, or physician for every scan, although obviously this is not always possible. Thank you.
Thank you, Professor.